We are going to be getting started here. I'm just going to give a very brief introduction. My name is Amy Wolf. I'm the programming coordinator for the Osterville Village Library. Thank you so much for joining us today on this absolutely brisk Wednesday. We're definitely getting our winter. And to those joining us on Zoom, thank you so much for being with us as well. Today, we have the pleasure of having Jennifer Mahoney and Stacy Grass from AZA Care Management with a program called Peace of Mind, Navigating Healthcare as We Age.
Thank you, Amy.
Thank you very much. So once again, my name is Jennifer Mahoney, and we are from AZA Care Management, and we're going to get into a little bit more about what we do at the end. But we want to first talk about everything that we're here to talk about and go over all the subjects and answer all the questions that you might have. But I will let my counterpart introduce herself as well.
And I'm Stacy Grass. I am a Sandwich resident. I'm a licensed nursing home administrator and a care manager for AZA Care Management. And happy to be here to talk about navigating healthcare because it's a big challenge.
And in case you wanted to see bigger versions of us, you can look right up here. But I am a social worker. I've been in healthcare for, I think, about 18 years now. I'm licensed in Massachusetts and New Hampshire. A lot of my background has been in hospice. And I've always worked with the older adult population and really enjoyed it. And I am certified in care management as well as hospice and palliative care. So let's go ahead and get started. And in terms of, we definitely have a lot of material and content that we're going to be covering, and you have folders with a lot of information in it as well that we'll mention as we talk. But I did want to, if you have any questions, we will leave time at the end for questions. But if there's anything pressing that you really want us to answer, just shout it out and we'll be happy to answer it. Because I know that I certainly have questions when I'm talking about some of these things and we're bouncing things off of each other. So it's only natural to have questions. So the first thing that I want to start with is what I refer to as the alphabet soup of senior healthcare. So many of you may have already been involved, whether it was yourself or a loved one, going to the hospital and hearing about long-term care and assisted living facilities and CCRCs and not understanding what all of this really means. How does it come together? What are people talking about? Why are they all acronyms? It sounds like a different language. It's very confusing. So we are going to try to talk about all of these topics that are listed here today. To some degree, of course, there's always more questions to be had. But the biggest topics we're going to cover today, we're going to start with advanced directives, of course, financial power of attorney and healthcare proxy, but we're also going to talk about living will, do not resuscitate, a MOLST, which is a bright pink form, and it stands for Massachusetts Order for Life-Sustaining Treatment. We'll talk about that a little bit. Then we'll get into insurance, of course, Medicare, Medicare Advantage, Medicaid, long-term care insurance, what that covers, but also what that doesn't cover, which can sometimes be even more important because I think sometimes you just assume you have insurance and that's just what you do and it covers everything, but that's not necessarily the case. So we want to make sure that you're prepared. And then in transitions in care needs and smart aging, is your home set up for you to remain at home if you needed to be wheelchair bound? Is that the best place for you to be? Would you prefer to be somewhere where there's more socialization or move closer to your children or move closer to a friend or all of those different sorts of scenarios that you can imagine? And then since we're putting all of this information in front of you and leaving you with probably more questions than answers, we're going to send you away with some resources too, so that you can assemble your care team, or at least start thinking about your care team for when the time comes that you might need it, and the different people to call upon and who you can utilize within this community. So perhaps the quickest way to get people's attention is to talk about saving money. So if you take a look at this graph here, it's a bar graph comparing the cost of elderly care with and without planning ahead. The green bars are an estimate of spending in that particular setting, while the red bar is an estimate of spending in that same location, but without the planning in place ahead of time. As you can see, the difference in expenses across nursing home care, assisted living, in-home care, emergency costs, out-of-pocket medical expenses can be significantly reduced with pre-planning ahead of time. And healthcare in general can be very expensive, especially as you age and you require more care. However, with pre-planning, the goal is to reduce some of those costs so that you could incur and be more proactive in your own planning. The alternative is being more reactive, ending up at the ER and, having to go to the short-term rehab with the first bed available. And that's certainly something that, people can help you out with in that situation, but we want to kind of avoid that and have you armed and ready to go with exactly what you want and where you're going and who to call and what you want to do it when the time comes that that's needed. Now, of course, besides the financial piece, the financial piece usually gets people's attention, but there are a lot of other reasons to plan ahead. And I'm sure you all have your own reasons, which is why you're here today and decided to stop by our program, which we appreciate. But the one reason that I want to highlight that I don't think gets talked about enough is better communication with healthcare providers. By pre-planning, it opens up the discussions between you and your healthcare providers, the physicians, the nurses, whoever's caring for you, to have those thorough conversations about future care options, advanced treatment, and also end-of-life preferences. It fosters a very proactive relationship and enables for more tailored care so that the physician understands where you're coming from and they can make recommendations based on your viewpoint and what you want. And you really end up becoming a true partner in your own care. And I can tell you that the physicians want that too. They want that partnership. They want that feedback. So don't be afraid to bring it up in a medical appointment or anything like that, because I know that people like that, or physicians like that, healthcare providers. Okay, so advanced directives. Now, you may already have some or all of these in place, as some of them can be very common. But essentially, advanced directives are essential tools that help ensure your healthcare wishes are respected when you are no longer able to communicate those preferences for yourself. And it's healthcare, but we're going to talk about the financial power of attorney. So it's the healthcare and the financial pieces. So basically, just make sure that everyone knows what your wishes are when the time comes that you might not be able to answer that question on your own. The first one is the living will. And it used to be a 2-page document in the back of the Massachusetts Healthcare Proxy Form, and now it's its own form called the Personal Directive. And basically, and there is a copy of it in your folder, but basically it takes you through all of the preferences regarding life-sustaining medical treatment if you're unable to communicate. So do you want a use of a ventilator? Do you want to be resuscitated? Would you want to go on dialysis, feeding tube, all of those sorts of things? Now, these aren't doctor's orders, but they can be utilized for people to understand what your wishes are. So they're not doctor's orders, they're not, legally in place or anything, but they can be very helpful to even just start those conversations when you're filling them out and talking to your family and your loved ones and your doctor. And then the piece that goes hand in hand with that is the MOLST form. And there is the pink form is up on the screen there. And basically the MOLST form is tied in with the living will because everything that's listed on the living will is also on the MOLST form, but it becomes an actual doctor's order because either a physician's assistant, a nurse practitioner, or a doctor have to sign this pink form.
Is everyone familiar with this form?
So MOLST stands for Massachusetts Order for Life-Sustaining Treatment, and there is a white copy in your folder. It's a 2-page document, so it's stapled. In real life, it's a pink page that's double-sided, and you would sign on each side. And sometimes people fill out one side and not the other. And the reason that I purposely included it is because it has a lot of good questions in there to start you thinking about these sorts of things, because it mentions a feeding tube. Well, do I want a feeding tube? Do I not want a feeding tube? But it even has time ramifications of how long do I want a feeding tube and those sorts of things. So in case you can't, oh, you definitely can't read that. But there is a copy in your folder.
And both sides of the form don't have to be completed and executed. You can only start in your journey with doing the first page with your physician. And the good thing about a MOLST is that it's portable from one place to another. And that differs from the do not resuscitate orders. Do not resuscitate orders, which are part of the MOLST, just one part. have to be executed at every location separately. Okay, but the most will say, I don't want to be resuscitated, or I do want to be resuscitated. And it's signed by a doctor, and a copy is as good as the original. So it just, you know, once you do it, you have it, you give it to the people in your life that you want to make sure that they know what your wishes are, including your physician.
Mhm.
And copies are as good as the original.
And it stays with you. Oh, sorry.
So is that a different form than the healthcare proxy?
Yes, it is. Yeah, the healthcare proxy, and we're going to get to that next, but the healthcare proxy is what designates who will be making your healthcare decisions when you're not able to. And there's also a copy of that in your folder as well. Yep, it's a lot of different forms.
And I think people in all one spot.
I find it can be helpful because you're talking about all these different things and, you know, it can, if there's too much information, it can go in one ear and out the other. So we wanted to give you the information, but also give you the tools to be able to reflect back on it and think about it and, you know, ask the questions that you need to from there. And so speaking of the healthcare proxy, that's the next advanced directive to talk about. In the healthcare proxy, it basically is a form. It's a few pages long, and you appoint a primary healthcare proxy as well as an alternate healthcare proxy to serve as the individuals who make your healthcare decisions when you're not able to. And now this is a form that you can do at any time. It doesn't mean that that person is making your healthcare decisions. It just means that if you're not able to, they would be the person. So in order for, yes.
These forms, they need to be notarized. Can you just fill them out and they're good?
The healthcare proxy does not need to be notarized. It requires 2 witnesses. The MOLST form, this pink one, requires a physician's signature or nurse practitioner or a physician's assistant. The financial power of attorney, I don't think,
Does need to be
it needs to
notarized.
be notarized.
Yes, the
Excuse me.
power of attorney does need to be notarized. We haven't discussed the power of attorney yet, but the most is something that you might want to introduce at your annual visit with your doctor, or any visit, you know, if it's something that's pressing on your mind and you feel like you need to have this document, because it really is an important document to have. You would just bring it with you to your doctor's office, and they'll either execute it at the appointment, or you leave it with them and they'll execute it and, you know, send you the original or have you pick it up, keep a copy.
Mhm.
And then, like I said, you can make copies and give it to other persons. Once it is executed by the physician, it is a binding document. And again, you could only start with the first page unless both pages are signed by the physician. Only the pages that are signed by the physician are binding. So, but you don't have to do both pages at the same time.
And so going back to the healthcare proxy, so what I wanted to highlight is that it's not automatic that that person is making those decisions. A doctor has to actually activate the healthcare proxy. They have to assess that you're not able to make those decisions. And then they would look at the paperwork and they would turn to whoever it is that's the primary healthcare proxy, and that person would make the decision. Now, the activation could be temporary or it could be more permanent. If you're in surgery and they need to ask someone a question, then it's probably more temporary. If it, you know, is at the end stages of dementia, then it might be more permanent. But it does have to be someone actually activating the healthcare proxy for someone else to make the decision. And I want to highlight how important it is to choosing a healthcare proxy. I think sometimes people can be very traditional in thinking about it and say, of course, I'm going to have my spouse as the primary and my eldest child as the secondary. Well, that might make sense, but then there might be, you know, maybe your eldest child or a different child is better equipped to handle those medical decisions and, you know, is in the healthcare field and can have those conversations with the doctors and disseminate the information to those that need to be involved. You know, so you want to make sure that you choose someone that understands your values and preferences, and even if they're different from their own, they will make the decision based on your values and preferences.
And that circles back to the living will. So if you've filled out the living will and you've put thought and you've put it down in writing as to really what your wishes are, and it's not easy because, you know, different scenarios, you know, might make you think differently, but it is you know, it's a document that would help a healthcare proxy to really understand what you want and what you don't want in the event that you cannot communicate with them.
And as I mentioned, the healthcare proxy needs to be signed by 2 witnesses. Those 2 people cannot be the healthcare proxy or alternate healthcare proxy. So you could complete the form at a doctor's visit, you could complete it at an attorney's office, or even just with, you know, different family members around. As long as there's more witnesses than just the healthcare proxy and alternate healthcare proxy, they just want to make sure that you're not, you know, the healthcare proxy isn't forcing you to put their name down there or something like that. And going along with the healthcare proxy, the financial portion of that is the durable power of attorney. And that's enlisting someone that can make, it's a legal document where you appoint a trusted person to manage your financial matters, which can be money, property, business affairs. It allows someone to pay bills, sign checks, sell property on your behalf. And the durable part of it means that even when you become incapacitated, they're still able to carry out those tasks. So it's definitely important to make sure that you do have a durable power of attorney for the financial part of it. And one important thing to keep in mind, unlike the healthcare proxy, is that it is automatically so-called activated unless it has a timeline listed in the document itself, which can sound a little bit scary because it means anyone can take this form and, you know, go to the bank and take out $100 or whatever it is. But what we always tell people is that a lot of times you're filling out the durable power of attorney for financial at an attorney's office. The attorney can hang on to it and they don't need to, your eldest son doesn't need to know that he's listed as the primary power of attorney. And then, you know, the attorney can let him know when the time comes that that's needed. The good thing about having that automatically activated is that, let's say, you know, you have a daughter in California and she calls all the time and then she hasn't visited in 6 months and she goes and visits her mom and, you know, the house is in more disarray than she normally keeps it and things are just different, then you can go ahead and you can, you know, go ahead. Oh, sorry, what is that? No. And then you can go ahead and you can, that daughter can go ahead and go to the bank and, you know, find out that the mortgage wasn't paid for a few months and you know, can resolve those matters. So there is certainly a benefit to having that, but you don't need to make it public if not. How did it change?
I don't know. Is somebody doing it virtually?
Sorry.
Going back to the healthcare proxy, I wanted to just make one more point. So it really is important to have 2 people, because if the first person is unable or unwilling, then you always have a second person available. I've used healthcare proxies in my professional life very frequently. You always start with the first person, and if the first person is unavailable, then you go to the second person. If the first person says, I'm overwhelmed with this, I don't want to do it anymore, then they've deferred to the second person. At that time, if you're still able to draw up a new healthcare proxy, you'd want to draw up a new one with a new primary and a new alternate. So the most recent healthcare proxy that is executed by you is the most valid. Okay, because some, you know, people do multiple healthcare proxies because circumstances change in their life. So the most recent is the most valid. And it does come up at times where there might be a squabble in a family and a family member might say, well, no, you're supposed to be talking to me. And I just need to see the most recent document, and I will always use the most recent document because that's what's legally binding by your wishes and your signature and your date on the document. So, and again, if that was a good question, that document doesn't need to be notarized. It only needs to be witnessed.
And another form is the HIPAA authorization form. And basically this is, you would do it at typically the hospital or the doctor's office. You may have already filled them out and may not even realize it. And it's just basically the people that are authorized to call for information so that, you know, they can call the hospital and say, oh, you know, so-and-so was admitted. Can you transfer me to their room? If they're not on the HIPAA form, they can't even say whether you're there or not. So it's important to have those people included. There are also organ and tissue donation questions, and those are included in the Massachusetts Healthcare Proxy Form. So just make sure you read that carefully and fill it out based on your preferences. And these are a lot of forms to think about and consider. The most efficient way to pursue completing this documentation is going to an estate planning attorney. They're very used to, kind of going through the estate planning documents. Many of them have packages ranging from 1,500 to 2,500, or it can be different depending on what you're looking for. But they could include a healthcare proxy, they can include a financial power of attorney, a living will. They wouldn't necessarily include the most form, but they would include the HIPAA authorization. So that's certainly something that you could consider if your mind is spinning right now.
And they
Um,
probably go a little further into a trust, and that type of advanced planning, but that's not where we're going to get involved.
Right.
Because that's really a specialty for them.
Mhm. And the last thing listed on here is funeral and burial preferences. And there's definitely not a form used for these sorts of things, but it's a good topic to start talking about with your loved ones so that they understand what your wishes are. Because for treatment, they want to understand what your wishes are and what you want when the time comes. But, afterwards, do you want a celebration of life, or do you want, a very traditional church ceremony, or do you want to be buried with the family in the family plot, or scattered off the south of France? Whatever your wishes are, that's something else that, sometimes people forget in all these pre-planning processes to talk about, but it can definitely be very important. Any other questions on advanced directives?
Most forms from another state, is it valid no matter what, or?
That's a good question. It varies from state to state. So every state has different rules and regulations. I can't tell you off the top of my head.
I would say if it's avoidable, if you can take that and when you move up here or, wherever it's from, and you go to the doctor and you can bring that and have them do the Massachusetts one, that would be ideal. However, if there was an emergency situation and someone just came up from another state and suddenly was in the ER and they have a do not resuscitate from another state, it might be doctor specific or hospital specific. I would like to think they'd uphold it. But I would say the safest bet is to make sure that, you just get that new documentation when you arrive here.
It's a good question. Very good question. There was a whole forum communication about that recently, and that's where I learned, every state is different. Mhm.
This is in Vermont, and actually there's a universal, they put it into so it's valid, so you can travel wherever.
That's wonderful
So-
Wow.
and progressive, but not every state's
Not every
document,
state.
is
Mhm.
portable.
Yeah, and they call it different things in different states. So I know in New Hampshire, it's the Pulse form. It's a provider orders for life-sustaining treatment. And it even has like a little pocket card included that you can put in your wallet. So it's a shame that it's not more universal for all the states, but they don't ask our opinion with these things. So we haven't been able to chime in yet. Okay, moving along to the big topic of insurance. Now, when we talk about insurance with older adults, we're typically thinking Medicare. Medicare, of course, is a federal health insurance program primarily for individuals 65 and older and is a crucial resource for Americans. It provides substantial coverage for a wide range of medical services, but it's not all encompassing. So understanding what it will and will not cover can help your beneficiaries make informed healthcare decisions and plan for out-of-pocket expenses, and then also look into supplemental coverage plans at the same time. So as you're probably all aware, most people become eligible for Medicare when they turn 65. It is not automatic. You have about 3 months before you turn 65 and about 3 months after you turn 65, a period of about 7 months to enroll. And then annually, there's an open enrollment period. And as you can see on the screen here, for original or regular Medicare, it's October 15th to December 7th each year. And then Medicare Advantage, it's a different time period. It's actually right now, January 1st through March 31st every year. And that's when you can change your plans. You can switch from regular Medicare to Medicare Advantage and vice versa. It just depends on, make sure you're using the correct open enrollment, depending on which one you want to switch to, if you are switching policies.
And are you all familiar with the difference between Medicare and Medicare Advantage? Just very briefly, Medicare Advantage combines, they get, the insurance company gets paid an annual amount of money from Medicare to manage their patients. And so they combine the primary and the secondary insurance into one. So there's some benefit to having a Medicare Advantage plan where it might cost you less money. You don't have to pay for a secondary insurance. They also, Medicare Advantage plans will also add things that Medicare doesn't cover, like dental, optometry. They'll provide sometimes a stipend monthly for just buying personal care needs. Sometimes they pay for transportation. The drawback on a Medicare Advantage plan is that you have to be in their network. So it's like an HMO. You have to go to their providers. They control the services that you receive. So you don't have as much freedom with a straight Medicare plan, but you do, if you take a straight Medicare plan, you do need to have a supplemental insurance to pay the 20% copay that Medicare doesn't cover.
And there are 4 parts to Medicare. It's A, B, C, and D. And Medicare Part C is actually Medicare Advantage, what Stacy was just talking about. So going back to the other 3 parts, so Medicare Part A is your hospital insurance. It covers when you go into the hospital. It covers a short-term rehab stay when you've been at the hospital for 3 overnights or more. It covers home health, which is, the visiting nurses and, because you might go from the hospital to short-term rehab to going home with visiting nurses, and that's all covered by Medicare. Hospice is covered by Medicare. And then Part B is your medical visits to your doctor. It also includes, I believe, many of the vaccines. It includes outpatient therapy, mental health services, durable medical equipment, as well as lab and imaging testing. And then, of course, Part C is Medicare Advantage. And then Part D is covering the costs of your prescription drugs and can also cover some vaccines that Part B doesn't cover. So in reviewing each part of them, we talked about what they do cover, and Stacy kind of touched on what regular Medicare doesn't necessarily cover. But just to point out what Medicare does not cover, it includes long-term care in a nursing home. So we mentioned how you can go to a short-term rehab, and oftentimes a nursing home and short-term rehab are the same physical facility. And so if you decide that you don't want to go home after the short-term rehab, or it's not a suitable setting for you and you want to stay long-term, then Medicare wouldn't cover the cost of that anymore. They just cover the rehab portion of it.
And Medicare only pays 100% of a rehab stay for 20 days. So that's where a Medigap insurance is very important. And the level of your Medigap insurance is very important, because not every Medigap plan will pay the co-insurance, which is significant. It's over $200 a day after day 20 if you have to go in for a short-term rehab. So making sure you have the proper coverage on your Medigap plan is key to making sure that you're not going to get stuck with a very large invoice for $250 a day. Let's just say you stayed, even 10 days, now you're $2,500. It adds up significantly. So, but there is a trick with your Medigap plan. If you do get caught in that scenario, you can always just call in Massachusetts specifically, and this doesn't apply to every state. You can call your insurance company and upgrade, and it will automatically upgrade the first day of the following month. So depending on where you fall in the month, you could end up with a big bill if you don't know that you have the proper coverage on your Medigap plan. So that goes back to the graph where, making sure that you're prepared and planning for it and knowing what your coverage is will save you money in the long run.
And one of the resources that we're going to be sending you away with is a medical insurance representative, which we definitely recommend. I know that I will definitely be utilizing that when I need to, because I work in healthcare and there's still so many coverage changes. And then I was talking to someone this morning and they said, even if you're on Medicare, every year you want to reassess the plan that you're on, because sometimes they can change the prescription drugs and what they cover and what they don't cover.
Yeah.
And by switching to a different program, it would be a better plan for you based on what your needs are. So you definitely, unfortunately, want to stay on top of that and make sure you're evaluating it annually.
And when you need to do that is usually when you're overwhelmed. Right? And it goes back to pre-planning, because if all of a sudden you're on 5 new prescriptions and, now your Med D plan, is not covering a significant amount, you can't change it until open enrollment the following year. So then you get stuck. Sometimes you can't pre-plan that.
There's only so much pre-planning you can do because we can't anticipate every situation that we might get ourselves into. But a few other things I just want to note that Medicare doesn't cover. I think Stacy already mentioned it, but they don't cover dental, hearing, or vision coverage. That's where you can purchase a supplemental plan, or a lot of the Medicare Advantage plans will cover that. They'll include a lot of that. It also doesn't cover vitamins, over-the-counter medications, incontinence supplies, home modifications. Once again, some of the Medicare Advantage plans will cover that as well. And it's important to note that the Medigap is designed to pick up the gaps within original Medicare. So there's not a need for Medigap when you're on Medicare Advantage. So you're either choosing original Medicare and maybe a Medigap plan, or you're choosing Medicare Advantage, and then you wouldn't need a Medigap plan. Now, we're not saying either one is better than the other. I would recommend looking into, your physicians, your network, what the different plans cover, the medications that you're on, kind of doing the whole history of all of that, and also calling a Medicare insurance representative, because they can definitely be very helpful. Now, the next piece is Medicaid. Medicaid provides coverage to low-income individuals and families, including children, pregnant women, adults, seniors, and people with disabilities. It's designed to help those who can't afford private health insurance by covering essential medical services. And in Massachusetts, it's referred to as MassHealth, but nationally it's known as Medicaid. And Medicaid often for older adults comes into the picture when an individual might be running low on assets and is reaching a point that they may no longer be able to pay privately for a nursing home stay. And at that time, then the family and the nursing home would talk, and a Medicaid application would be filed, and they would send all of the paperwork. And so that Medicaid would end up becoming the primary biller in that case. So Medicaid does cover room and board for long-term care.
So there's a distinction between community Medicaid and long-term care Medicaid, and how you qualify for both. So if you're in the community living at home, or even living in an assisted living or independent living environment, they base your eligibility for Medicaid on income. So they look at your monthly income. If you're staying in a nursing home, they look at your assets. It's a very different qualification. So a lot of people don't understand that there's a difference between community and long-term care Medicaid, and how the qualifying works. Everybody's heard of the 5-year look back, I would imagine, on Medicaid. Is everybody familiar with that? I think if you're not, it just means that you cannot impoverish yourself purposefully to be able to qualify for Medicaid within 5 years prior to applying. So and if it does happen that somebody needs Medicaid and they have transferred a significant asset, then Medicaid will pose a penalty, which is just based on a daily dollar amount, which is the average cost of a nursing home stay in Massachusetts. So let's just say it's $450 a day divided into how much money they felt that was inappropriately transferred. And that's how much of a penalty that person would get. And then it comes down to trying to figure out how to pay the nursing home, what Medicaid won't pay the nursing home, which oftentimes the nursing home doesn't get paid. I can speak from being a nursing home administrator and being on the end of trying to collect all the money. Oftentimes the nursing home doesn't get paid, but what happens is there can be a transfer, and then the nursing home won't take the person back. If the nursing, if somebody goes to the hospital, then the nursing home may not take the person back.
But one way to have a payer source for the nursing home is the final type of insurance that we'll talk about is long-term care insurance. And this can help pay for services and care. It covers costs associated with extended care services that are not typically covered by regular health insurance or Medicare. So this includes assistance with daily activities, or what we call ADLs, activities of daily living, which can include bathing, dressing, eating, toileting, incontinence care, ambulating, and I might be missing a couple of them. But it basically covers the care in settings like nursing homes, assisted living facilities, or even in-home care. It can cover skilled nursing care, home health aides, adult daycare, respite care, and hospice care. It's advised to purchase a policy decades before it's needed because they do a health screening assessment, which your coverage will depend, the coverage and the cost will depend on pre-existing conditions and, all of that. Whatever they can catch, they're gonna utilize to their benefit. But when the time comes, it can certainly be a very, very beneficial payer source to have on board with you. I will say that one thing to note about long-term care insurance is that, it typically, you're typically eligible to start utilizing the policy when there are 2 or more ADLs that you need assistance with. So let's say you're at a point where you need assistance with bathing and dressing in the morning. Well, then you might be eligible to start using your long-term care insurance. Now, it doesn't automatically kick in. Nothing's automatic, of course. You have to open a claim. So, yourself or your loved one would go ahead and open a claim. Oftentimes there's an elimination period, which is basically the initial period of time in which you're paying for services where the insurance company isn't yet paying. So it's important to open that claim as soon as you need to, because oftentimes the elimination period can be 30, 60, 90 days. Sometimes there's no elimination period if you're lucky. But it's important to start utilizing those things as soon as you need to. And as any insurance, they don't make it too easy. There can be appeals, there can be claim denials, there can be a lot of paperwork, there can be, a lot of complications. So definitely make sure if you have long-term care insurance that, there's someone assisting you with that, whether it's an attorney or, someone close in your family knows about the policy and can help utilize that when the time comes. Because we definitely see way too many people buy into these policies decades ago and never utilize them because it's just so frustrating. It's overwhelming. It's too much paperwork. It's all electronic and they're not used to electronic. And, there's just so many different reasons. And we sometimes get involved in those cases too, just to try to help people get paid for something that they paid into for so long that you just don't want to see, go to the wayside when they're paying so much for their care already. So it can be a shame to encounter that sort of thing. But long-term care insurance, you have to work to get all those dollars back, but it's definitely worth it to pursue that if you do have a policy.
Sometimes there are good clauses in the policy that will help meet the elimination period that you don't even realize. I've recently worked with 2 different policies that if there's no elimination period if they're paying for home care. So, and then while you're using home care, if you use 100 days worth of home care for a 100-day elimination period, now your elimination period is satisfied. So sometimes it seems like, oh, I have a 100-day elimination period, but there's other clauses in the policy that are really important to understand. And, that a family member should, or, probably whoever your healthcare proxy is, should really have a copy of your long-term care insurance policy if you have one. And if you don't have one, we all know that they're very cost prohibitive as we age. There's now riders to insurance policies, and that's sort of a new way of doing it. So you can get a life insurance policy, like a whole life insurance policy, and then there's a rider where you can access the funds before death, to use while you're alive towards long-term care. So it could be a more affordable approach if you've reached, an age where it is cost prohibitive to just get a straight long-term care insurance policy. But it, you know, so it's good to talk to a financial person who
Mhm.
specializes in that, because there are all kinds of new options.
And so this slide, we talk about the aging journey, which, as you can see, the health and ability to function, you need more assistance over time. Home sweet home, that setting can change over time depending on what your needs are. And then of course, the cost of care goes up over time. The more care you need, the more expensive something's going to be. But I want to talk about those different, those different levels of care, the home sweet home. So going back to some of the alphabet soup of senior health care, I want to touch on all 8 of these levels of care here. So starting with the top left, independent living facilities. Typically, it's an apartment in a building where they have services, whether it's, meals, activities. They might have home care services that you can purchase at a different cost. Sometimes they have nursing in-house that you can also purchase at a cost. Each one can really vary depending on what they cover, and also depending on if they have an assisted living nearby or, those different sorts of things. But the underlying idea of independent living is that you can live independently in that apartment on your own. And then if you need additional help, like you need someone to come in and help with the cleaning or the laundry, then you would pay privately for that person to come in. And oftentimes the facility itself has contracted providers that can come in and assist you with all of that.
Or staff.
Yes. And then if you were to decline and wanted to move on to the next level of care, and this isn't necessarily, kind of the path that everyone needs to go, but these are just, my way of describing the different levels. So the next step would be assisted living level of care. And assisted livings provide nursing and or aid staff 24/7. They provide assistance with those ADLs that I mentioned, the bathing, dressing, toileting, all of that. They provide medication management. They have tons of daily activities, just like a calendar here, I'm sure has, as well as meals. And then within assisted living facilities, or within some assisted living facilities, there's another layer of assisted living, which is called memory care. And oftentimes they're a smaller unit within a larger building. Sometimes they're a standalone facility, just depending on the company and the building and whatever it might be. But this is for individuals with dementia diagnoses that typically require more supervision and more care. They are typically secure facilities, so individuals can wander. Many of them have indoor courtyards or indoor-outdoor courtyards so that they can go inside and outside, especially, when it's nice around here, and not feel that, they're restricted to, just one straight hallway or something, but also maintaining safety at the same time, of course. And then the next level is skilled nursing facilities, and they are commonly called rehab or short-term rehab. This is where you use your Medicare benefit after hospitalization, like I mentioned earlier. They are also commonly called nursing homes, and typically individuals are there short-term, but they can be there long-term. When you're there short-term, you're receiving the rehab or the therapy services, your physical therapy, occupational therapy, and speech therapy. And the whole goal is to rebound back to your baseline so that you can go home. Now, if you don't rebound or you can't go home or whatever, might be going on, then you might switch over to long-term care, which might be in the same facility, but maybe on a different wing, or it might even be the same room. It varies from place to place. But essentially, long-term care is when you're staying at the nursing home facility long-term and you're not able to rebound back to that independent level where you can go home, or, you can't afford to have the 24-hour care at home or whatever it might be. There are a myriad of different reasons. So those 5 levels of care that I just mentioned can represent a typical aging journey as the individual progresses. The next 3 aren't necessarily in any sort of order. So home care. Home care essentially refers to any care you receive in the home, any care you receive that comes into the home. This is often a combination of Medicare covered home health services as well as private pay or the long-term care insurance covered services. In the state of Massachusetts, you can receive a certain amount of subsidized home care services through the Aging Service Access Points. Has anyone heard of Elder Services of the Cape and Islands? Yes, okay. So they are the local, what they call ASAP, another acronym, of course, around here, and they can offer some services, and we'll touch on that a little bit more when we talk about the different resources, because it can definitely be a great resource, and they have a lot over there. But there can also be some things to keep in mind when you do go that route as well, in terms of things to be thinking about. The next one is a CCRC, or a continuing care retirement community. And they are usually a large campus with multiple levels of care that allow residents to transition to the different levels based on their needs. So they might have skilled nursing, independent, assisted, memory care, and long-term care all on the same campus. And they offer, of course, the housing, the healthcare, the support services, all in one location, and the whole benefit of it is to be able to age in place as your needs change. Now, that doesn't mean that you're always going to be in the same room or even the same building, but you're going to be under the same umbrella, so to speak. And you're also going to be receiving priority if you are in the independent living and you end up at the hospital, and then you have to go to short-term rehab, and you're at a CCRC, well, then you're going to be bumped ahead of other people at the hospital that want to go to that same rehab, because you're already established in their system, and you're going to get priority of that bed over another person that's out there. A lot of them can require, or most of them I think require, entrance fees or investments upfront, in addition to monthly fees that help you secure the access to the various levels as your needs change. But it can also be a good financial model to help you design and configure what the numbers will look like and what they'll look like over time as your needs change.
And keep you from having to move from place to place as
Mhm.
you decline.
So there is actually one CCRC on the Cape. It is
Mayflower Place
Yeah.
in Yarmouth.
What's it called?
Mayflower Place?
It's Maplewood at Mayflower Place. They have independent living, assisted living, short-term rehab, and long-term care. And then they also have Mill Hill right down the street, which is their memory care. So that's the only one on the Cape right now, when I looked it up. There are a number of other ones that offer like independent living and assisted living, but don't necessarily offer as many levels of care as Mayflower Place does.
Yeah, Mayflower is the only one that really has an attached skilled nursing facility. And there's a lot of places to choose from on Cape Cod that are independent, assisted, and memory care, all in the same place. And long-term care. Long-term care and short-term rehab are sort of a separate little, oftentimes just an individual building.
And now, of course, I don't have it up here, but everyone is familiar with hospital level of care. You know, we grow up knowing you call 911 and you go to the ER with anything that's going on. And that, of course, can happen, throughout the continuum of the aging process and at different levels. The only time it becomes less common or uncommon to seek hospitalization is if the individual is on hospice and the individual themselves have chosen to be a do not hospitalize, or they've chosen comfort measures only or palliative care. And hospice can be provided, it's covered through Medicare, and it can be provided at your home, it can be provided at a nursing home, assisted living facility, wherever you are is where it can be provided. And they don't pursue aggressive measures in hospice, but that doesn't mean that they don't treat. So if there's a question of, some symptoms arising and you're having difficulty breathing, well, they're not going to run all of the diagnostics to, figure out what the difficulty breathing is from, but they're going to treat the difficulty breathing. And that's, of course, going to be your choice when that time comes of when to come on hospice. Typically, people make that decision after a very long health journey, and they decide that they don't have a quality of life anymore, or they don't want to keep going through this, or they don't want to go back to that place, which is usually the hospital. So everyone makes that decision at different points, but it is always an option in the background there.
I find that many people hear the word hospice and they automatically say no. No. And it's really worth exploring, because hospice can be part of a person who has memory loss, who, is declining. It could be a part of their life for a long time. Technically, you need a 6-month diagnosis, but nobody has that crystal ball on the 6-month rule, right? And so the doctor will say, this person has end-stage Alzheimer's, and they qualify for hospice. because they've had weight loss or, they're not eating the way they used to. And it can be a really wonderful addition to the care that you are receiving, just the basic care that you're receiving, because they provide services to the whole family, not just to the individual. And they provide spiritual services, they provide activities, they, companionship. So it's not just, end of life. No, I don't want to talk about hospice. And, it's different with, you get a different reaction with different people when you bring up the word hospice. Some people are aware of all the wonderful benefits and are not afraid of it. And other people think it's just, they're gonna give mom morphine and mom's gonna, and kill her.
Yeah.
You
Jimmy
know, I mean,
Carter
that's
was on-
extreme.
Jimmy Carter was on hospice for like over a year, I'm pretty sure. And it's funny because I worked in hospice for a long time, and it was the H word that no one wanted to hear. And if you described the program and what it provides, everyone's like, what is that? Leaning in and, oh, we get that and it's free, it's covered through Medicare. And then you say, oh, it's hospice. They're like, oh, no, no, no. So you can explain everything and just not use the word, and we used to have families tell us that, just don't use the H word around them.
I
Like,
know.
okay.
Well, it can start with the word palliative care.
Mhm.
But, and, on a personal note, I lost a sister and she was on hospice, and I was very involved with her care at the end. And they reached out and followed me for a year.
Mhm. Yeah. Yeah, they follow you through the anniversary of the death, all of the holidays. They have a lot of different resources. So when that time comes, no one wants to need that, but when that time comes, it can be a great resource for the individual as well as the family.
Yeah, it was really nice to, have that follow-up and that outreach afterwards.
And speaking of resources, so this is a list of, kind of the different topics or the different, individuals, if you want to assemble for your care team. It sounds like Avengers or something. And in your folder, I think it's the last page on the right side, it has actual, a couple of different recommendations for attorneys and financial planners. And, just to kind of get you started, they're people that we have worked with. It's not that you have to necessarily, call those people or work with those people. But we know that they're definitely, reputable and would be able to assist you. But just to go down the list quickly, so the primary care or doctor's office, that's definitely a great place to start. It can particularly be helpful if you have a physician that is able to spend more time with you than many physicians today, whether it's a concierge physician or someone that you've been with for a long time that can really, sit with you and talk to you about these different things. The doctor's office would also be the one to write the prescription for durable medical equipment to be covered under Medicare and authorize home health or hospice services. Then there's the local Council on Aging, the Barnstable Council on Aging, which is everyone familiar with the Council on Aging? Okay, they cover a ton of activities. They have a full calendar. If you stayed there for a day, you'd be exhausted. They offer so much. It's wonderful. If you haven't been there, check out the Barnstable Council on Aging. You can check online or go in person. They just have so many different offerings there to take care of the community. It's really impressive what they do.
Or if you live in Yarmouth or Mashpee, each town has their own.
Yes. And then Elder Services of Cape Cod and Islands. Those are the subsidized home care services that can be provided. And I did put the phone number on the list in your folder, so you could reach out to them. If you're interested, you could just call and say that you're interested in an intake. Now, the one caveat with them, being the subsidized services that they are, is that there can be wait lists. There can be wait lists to either be seen for a screening or to get services. So just be mindful of that, but it certainly doesn't hurt. They also, all of them have an intake and referral department. So if you have questions and you want to run it by them, they could be a good resource to call, as well as the Council on Aging. Those are probably the two places that I would start with for those sorts of things. And then attorneys and financial planners, of course, play a vital role in helping you navigate the legal, financial, long-term care planning As I mentioned, the attorneys can help with estate planning, drawing up the advanced directives documents, and also just help with elder law advice in general. Medicare insurance representatives, which we kind of touched on already. But there are individuals out there that can specifically provide guidance and support to navigate the complex world of Medicare, and helping you select the best coverage options based on your needs, your budget, and also eligibility. And the final resource or team member that you want to have on board is a care manager. And as you might remember when we introduced ourselves, we are care managers. So we're just going to take one slide and tell you about us. Oh, there we are. Okay, so we're from AZA Care Management. We are in the process of rebranding soon to Live Well Care Management. So if you hear that name in the future, that's us too. But AZA Care Management has been around in the Boston area for about 30 years. And then we newly expanded down to the Cape about a year ago when we brought Stacy on board with us. But this is our team of care managers, including myself. All 9 of us have extensive experience in the senior care industry. We hold advanced degrees, are certified and licensed, active members of related professional associations. You have to have a lot of experience to become a care manager. I think the minimum amount of experience, I think it's actually me on the team, is 18 years of experience in healthcare. And so we've all been through these different situations of how to navigate the hospital situation, how to talk to the rehab, and how to deal with the doctor at this place, and what to advise the family at home with their mom with dementia, all of those different sorts of scenarios. And so,
Yeah, a very strong advocacy. And, from a third party perspective, which sometimes is really helpful with managing dynamics.
Yes, and it's mostly private pay our services. But as we mentioned, long-term care insurance earlier, depending on your policy, whenever I take a call, I always ask them, do you have long-term care insurance? Because if we can get our hands on that policy, we found out that people have gotten reimbursed when the bills have been submitted when they didn't expect to be. So, we'd like to dig through that policy and figure out what benefits that people can get that they're not aware of or not utilizing at the time. And we can also be used as little or as much as is needed. So we have some individuals that might not have, a lot of family nearby, and they might rely on us more, maybe on a daily basis or weekly basis. And we have others that, have a lot of support, and they might reach out annually to us if something's going on, or, someone's in the hospital, or someone's declining at home, or they just have a general question for us. So we're kind of used as like elder care experts, and kind of how to navigate the healthcare system. And I mentioned all those difficulties with long-term care insurance. Sometimes we get hired solely to help with long-term care insurance. Stacy actually had a client recently that she won an appeal, which is we were very excited about, because long-term care insurance does not make it easy to get paid for anything. So we were very excited to win an appeal for a client, recently. And so we can certainly help with that. We have individuals call us all the time that need help navigating, because all of a sudden they get audited by their long-term care insurance, and they sent a check to someone, and it was 3 months ago, and they have no idea where a copy of the check is, and they don't know what to do, and completely overwhelmed, on top of, caring for their loved one and everything else they have going on.
Sometimes a long-term care insurance will actually they usually always send a representative out to sort of go to the home and assess the situation. And if they're talking to the person receiving the care, sometimes the person receiving the care doesn't really acknowledge, how much care they're receiving. And they're like, no, I can do that by myself. And they don't even realize what they're doing, And if you can do it by yourself 10 times a day, and there's one time a day that you can't do it, then you qualify. And so it's that little loophole, and people don't really understand that, that in a nutshell, if, it's always your lowest ability, not your highest ability, when it comes to trying to get your insurance company to cough up.
And one note that I want to mention of when a care manager can be really beneficial to people is if you have family living at a distance, maybe, a daughter in California, a son in Florida, or you're a solo ager and you don't have, people around here that are able to assist in that same way, we can be hired to kind of be those boots on the ground. Now, we can't serve as healthcare proxies, but we could, get a call and one of our clients goes to the ER, then Stacy can run over to the ER and say, okay, I'm the care manager. Here's the client's healthcare proxy form. These are her wishes. This is the best number to reach that person. And we would be talking to the healthcare proxy saying, okay, mom went into the hospital. She's doing okay. The doctor's going to call in 20 minutes. She's going to be admitted, kind of be the person coordinating locally, if you don't have someone else that's able to assist with that. And we are on call 24/7. I was just talking with a client's daughter recently when she was wondering, what happens in emergencies? And, it's not, people don't always go to the hospital or have emergencies Monday through Friday, 9 to 5. And so we always have a care manager on call that's able to assist and could talk to the doctor or could follow up with, whoever it might be.
Having advocacy at the hospital is really key to getting good health care. And, I find that the older generation sometimes is like, well, the doctor knows best and I'm never going to question what the doctor says. And that's not really the best way to go. Different doctors have different opinions. And, when you are going to go to short-term rehab, if you're in the hospital and, you think you just need a short visit, sometimes the case manager will decide for you instead of letting you decide where you want to go. And, or say, call up the family member and say, I need a decision today, right? The family member does have the right to say, I need a day. I need maybe 2 days, which it might be pushing it because this is a hospital, but, you don't have to let them push you out the door. You can stand up for yourself and say, no, I don't want to go to that rehab facility. It doesn't have a good rating. Well, there isn't a bed, well, let me look and come up with another option. Let me work on it. Give me a day to work on it. Sometimes quite often families don't know that they can do that. Care manager can come in and do that for you.
Mhm.
And so it's valuable, so valuable in the long run with a hospitalization. Just somebody who knows how to manage the process.
Mhm. Absolutely. So I think that's all we have for you today. But does anyone have any questions that they saved up till the end?
Little overwhelming amount of information. Did everybody learn something today, I hope? A lot of people have been on their own journeys or journeys with families, journey as a caregiver. Sometimes we come in and we help just when, your family is overwhelmed and maybe you just need a third party who can come in and, just sort of bring it all together and be, almost a mediator. Sometimes that's helpful.
You get paid for call, for lunch, do you get a yearly contract? How do you?
For our services?
Yeah.
So we bill hourly and it's broken down into 15-minute increments. So, and we bill for kind of anything related to the client. So whether it's, a visit in person or it's emails, phone calls, research, the care manager just keeps track of all of that. So there are some weeks or months where we don't bill the client if they don't need us for anything. And it's just zero. And then there are other times where, it's many hours or something like that. And we always talk to the families, from the very beginning to try to, we don't want any surprise bills or anything. So we try to make it very clear that, like Stacy had a client recently that, the daughter had financial constraints and she wasn't local, but she wanted to have someone local. And so she said, well, don't go over 5 hours. And we said, okay, that's a place to start. And, we've been able to help her so far. And when we're reaching that 5 hours, we talk to her and have a conversation and see what she wants us to do. But we like to keep the dialogue open so that, it's not just all of a sudden, sticker shock. It's $195 an hour. And we do also have a program called our Peace of Mind program. And it's basically for the active, independent individual who might be you know, a solo ager and wants to be prepared for when they might need more assistance. And it basically brings you on board with us and has a care manager. So you're assigned a care manager. And then that care manager, let's say it's Stacy, would visit you quarterly. And so every 3 months, Stacy would call and she would schedule a visit and she would check in to see, okay, how are you doing? What does the home look like? Do we need to, you know, can we recommend grab bars or, you know, tell us about your recent doctor's visit or, just to kind of get to know you and your medical situation so that, knock on wood, if you were to go to the hospital tomorrow, you could, have the EMTs or, have a family member call us and say, oh, she's going to the hospital. We need Stacy to run over there. And then, Stacy would be the care manager and she would have already be familiar with you. So she'd be able to show up with the healthcare proxy and say, okay, it's the niece. She lives here. This is the best number to reach her. This is her preferred short-term rehab. She's on this medication, so be mindful of that. And, all of those little sorts of ins and outs that, unless you know the person, you don't know all of those little things
Right.
yet.
Just be an immediate hospital advocate. I'm sure probably most of us have had visits to the ER where, it can be kind of a nightmare in the ER and the hospitals are full. And you just don't know what's going on. It's, everybody, I feel strongly, no matter how old you are, nobody should ever be in the hospital in the ER alone. Because you're the one that's sick. You need to have somebody else there with you. Somebody who can speak coherently for you because you might not be firing on all, but, yeah, and so the Peace of Mind program is something that just allows us to be, already familiar with the patient, which is, very important. And so, and that program is,
It's $2,000 annually.
any other questions?
Well, thank you so much for having us. I appreciate everyone braving the cold and coming out here and, I hope we didn't overwhelm you. I hope we gave you some answers.
I hope you found it helpful
Trying to
and
arm you with the
informative.
information.
I think, a big takeaway is knowing that care management exists, right? Sharing it with your friends, because we're trying to reach out to the sandwich generation or the older population that might need it, but the sandwich generation are the children that are taking care of the parents as well, right? And, people don't even know it exists,
Yeah.
and they can be overwhelmed and not know where to get help.
Thank you so much. And if anyone wants to grab an extra folder, if a friend couldn't make it or something, feel free. We have extras.